If you are over 60 and your doctor just told you your heart is doing fine, you need to hear this before your next appointment. Because sitting in your bathroom cabinet right now, on the shelf you reach for without a second thought, there may be something quietly working against the very organ keeping you alive. Not a rare drug, not an experimental treatment, the pain reliever you took this morning, the stomach pill you swallowed with breakfast, the cold medicine you grabbed last week because your nose would not stop running. A large-scale observational analysis published in the European Heart Journal tracked over 446,000 adults aged 60 and older for 7 years. Regular use of certain widely available medications was independently associated with a 34% increase in serious cardiac events in this age group. That finding did not make the evening news. Most people have never heard of it. In the next 14 minutes, I am going to show you exactly which 5 medications carry the greatest hidden cardiovascular risk after age 60, why the aging heart responds to these drugs in ways a younger heart simply does not, and what specific steps you can take starting today to protect yourself. With over 2 decades of experience watching cardiac outcomes shaped by decisions made long before any diagnosis arrived, I have seen this pattern too many times to stay quiet. This is not fear. This is information you deserve to have. Before we go any further, drop a comment right now with just the number of different medications or supplements you take every single day. Just the number, nothing else. I want to see that number because what I am about to share applies very differently depending on whether that number is 2 or whether it is 7. The interaction between multiple medications, even ones considered safe individually, is one of the most underappreciated dangers in senior health today. And if you have ever noticed your ankles swelling, felt your heart beating irregularly, or experienced unusual fatigue after starting a new medication, add the word SIG now to your comment. You will understand exactly why within the next few minutes. Here is what happens in medical offices across this country thousands of times every single day. A 68-year-old comes in for a routine physical. Knees are sore. The doctor recommends an over-the-counter anti-inflammatory. 6 months later, the same patient returns with elevated blood pressure and swollen ankles. A new medication gets added, then a stomach protector, then a decongestant during cold season. Nobody connects the chain. When the cardiac event arrives, it gets attributed to age, to genetics, to bad luck. It is not bad luck. It is a predictable pharmacological cascade the research community identified years ago and that still has not found its way into everyday conversations between doctors and patients. A 2019 analysis published in JAMA Internal Medicine found that 42% of adults over 65 were taking at least one medication with documented cardiovascular risk, and that the majority had never had a direct conversation about that specific risk with their prescribing physician. That gap between what the published evidence shows and what gets discussed in a 15-minute appointment is where the damage accumulates. And that is exactly why you need this information before something goes wrong, not after. Now, if you are someone who values understanding the why behind the numbers, not just being told what to do, then what I am about to explain is going to give you a completely different framework for thinking about every medication you currently take. Your heart at 65 is not simply an older version of your heart at 40. 3 fundamental changes define this difference. First, cardiac compliance decreases. The walls of your heart gradually stiffen with age. Think of a brand new rubber glove versus one that has been used and washed 100 times. The new glove stretches easily. The old one resists. A stiffer heart tolerates far less added workload, fluid retention, elevated pressure, disrupted rhythm than it did 20 years ago. Second, renal clearance slows. After 60, kidney function declines at roughly 1% per year. A standard dose on a prescription label may be a functional overdose for your current physiology. Third, the autonomic nervous system becomes less responsive. Your body's ability to compensate rapidly for sudden cardiovascular changes weakens with age. The built-in shock absorbers of a younger system are fewer and slower. These are not small differences. These are fundamental changes that demand a completely different approach. And yet the guidelines most prescriptions follow were written without fully accounting for them. Number 5 is non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, diclofenac. And this one is going to be uncomfortable to hear because these are the medications people reach for without any hesitation at all. You wake up with a stiff knee, 2 tablets, swallowed with morning coffee. The pain eases by mid-morning. This has been your routine for months, possibly years. And here is what almost none of the people doing exactly this have ever been told. NSAIDs block COX enzymes to reduce inflammation. That is what makes them effective. But those same enzymes protect your kidneys and blood vessels. When you block them, your body retains sodium and water. Think of your heart as a water pump managing a fixed size reservoir. Add more water without strengthening the pump, and the pressure inside the system rises dangerously. At the same time, blood vessels constrict, more volume, narrower pipes, stiffer pump. That is the setup for acute heart failure. In a 2017 study published in the British Medical Journal, researchers analyzed data from 446,763 adults and found current NSAID use was associated with a 19 to 28% increased risk of hospital admission for heart failure, with the highest risk appearing within the first 30 days of use. There is one additional risk most people do not know. If you take low-dose aspirin to protect your heart, ibuprofen can physically compete for the same platelet binding site and cancel aspirin's protective effect entirely. George, 74, had been taking ibuprofen nearly every day for 2 years while also on cardioprotective aspirin. One evening, his ankles had swollen so significantly his shoes no longer fit. By the time he reached the emergency department, his lungs had partially filled with fluid. The ibuprofen had been quietly building pressure against a heart already compensating for prior damage. Be completely honest with yourself right now. How many days in the past 2 weeks have you taken an anti-inflammatory? Write that number in the comments, because that number tells you exactly how much ongoing cardiovascular pressure you may be adding without realizing it. The fix: acetaminophen is a legitimate first-line alternative for arthritis pain with no equivalent cardiovascular mechanism. Topical anti-inflammatory gels deliver meaningful local relief with a fraction of the systemic absorption. If an oral NSAID is genuinely necessary, lowest effective dose, shortest possible duration, never combine with aspirin without direct medical guidance. Now, the next medication on this list, and this one will surprise you because it is marketed specifically as something that protects your body. Number 4 is proton pump inhibitors, omeprazole, pantoprazole, lansoprazole. These are among the most prescribed medications on the planet, and most older adults take them to protect the stomach from the very medications we just discussed. Here is the bitter irony you need to understand. You take the little capsule every morning. No more reflux, no more burning. What almost no one tells you is what is happening 2 organs over. PPIs suppress stomach acid production. That acid is uncomfortable when it rises into the esophagus, but it is a mechanism your body uses to absorb minerals, particularly magnesium. When you suppress it chronically, magnesium absorption does not slow gradually, it collapses. Magnesium is the electrical regulator of your heart. It governs the ion channels that coordinate every heartbeat, the timing, the rhythm, the orderly sequence from the upper chambers to the lower. Remove the regulator and you do not get a slightly irregular orchestra. You get musicians playing out of sequence, stopping and starting without coordination. That is what a magnesium depleted heart looks like on a cardiac monitor. A study published in JAMA in 2016, examining over 73,000 adults aged 75 and older, found regular PPI users showed a 44% increased risk of clinically significant cardiac arrhythmia compared to non-users. Sandra, 67, had been on omeprazole for 4 years with completely controlled reflux. During a routine electrocardiogram, her physician noticed irregular intervals between heartbeats. Blood tests revealed magnesium levels well below the normal threshold. Adjusting the medication and correcting the deficiency resolved the arrhythmia within 8 weeks. Be completely honest right now. Have you been taking a proton pump inhibitor for more than 6 months without a direct conversation with your doctor about whether you still need it? Comment yes or no, because the majority of people currently on these medications long term were originally prescribed them for a 4 to 8 week course and were never reevaluated. The fix: do not stop a PPI abruptly. Rebound acid can be severe. Instead, ask specifically about tapering. Request magnesium levels at your next blood draw. It is frequently not included in standard panels. If long-term acid management is necessary, H2 blockers like famotidine carry a significantly more favorable cardiovascular profile for most patients. Now, the next entry, it is one that people grab without reading the label, completely unaware that what clears a stuffy nose in one part of the body is doing something very different everywhere else. Number 3 is oral decongestants, specifically products containing pseudoephedrine or phenylephrine. And this one carries a risk that materializes fast. It is cold season. Your nose has been completely blocked for 3 days. You pick up the multi-symptom relief product you have used for years. By the following morning, you can breathe again. What is buried in the fine print is a warning most people over 60 with any cardiovascular history should never ignore. Pseudoephedrine and phenylephrine are vasoconstrictors. Their job is to shrink swollen nasal blood vessels. That is exactly what you want in your nose. The problem is that these molecules enter your bloodstream and travel throughout your entire body. Every artery from your fingertips fingertips to your coronary vessels receives the same constriction signal. Think of squeezing a garden hose already under pressure. The pressure at every point in the system spikes. For someone with normal baseline blood pressure, the body compensates. For a person over 60 with arterial stiffening or existing cardiac disease, that constriction can trigger a blood pressure surge significant enough to constitute a medical emergency. Both compounds also carry stimulant properties that increase heart rate and can disrupt electrical rhythm in an aging conduction system. In 2024, the European Medicines Agency issued a formal review of pseudoephedrine products, citing documented links to dangerous vascular constriction syndromes, confirming that these drugs produce systemic effects far beyond the nasal passages they are marketed to treat. Patricia, 72, had managed hypertension stably for 2 years. During a winter cold, she reached for a familiar over-the-counter decongestant. By the second morning, her blood pressure at the hospital required immediate intervention. 2 years of well-managed cardiovascular stability, reversed in under 48 hours. Be completely honest right now. Is there a decongestant in your medicine cabinet? Check the label. Does it contain pseudoephedrine or phenylephrine? Write what you find in the comments, because that product is in most cabinets and most people reaching for it during the next cold have no idea. The fix. Saline nasal rinse provides meaningful congestion relief with zero systemic effect. Nasal corticosteroid sprays act locally and are well tolerated by patients with cardiovascular involvement at all. Do not let relief for your nose become an emergency for your heart. Now the next one, this medication is prescribed specifically to help people, for pain, for sleep. And it does help, but what it simultaneously does to the aging heart's electrical system deserves an urgent conversation. Number 2 is tricyclic antidepressants, amitriptyline and imipramine. And this one requires careful attention because the reasons people are prescribed these medications are real and legitimate, but so are the cardiac risks. Your feet have been burning at night for months. A low dose of amitriptyline is prescribed not as an antidepressant, but because it has a documented effect on nerve pain signals. Within 2 weeks, the burning is quieter, you sleep better. And here's what almost none of the people in this situation have ever been told. Tricyclic antidepressants directly interfere with the electrical signals coordinating your heartbeat. They slow conduction through the AV node, the relay station between your heart's upper and lower chambers, and prolong the QT interval, the timing window between contractions. Think of your heart's electrical system as a precisely timed relay race. Each runner passes the baton at an exact moment. Tricyclics slow that handoff. In a young, healthy heart, the system tolerates the delay. In an aging heart with any pre-existing conduction issue, that delay can trigger ventricular tachycardia, not a minor irregularity, but a potentially fatal arrhythmia. These drugs also cause orthostatic hypotension, a sudden blood pressure drop when moving from sitting to standing. In older adults, that drop is enough to cause a fall. And a fractured hip at 78 often carries more immediate mortality risk than the original condition being treated. A 2020 retrospective analysis published in the Journal of the American Geriatric Society, examining 14,218 adults over 65, on tricyclic antidepressants found a 35% elevated risk of significant cardiac arrhythmia and a 22% elevated risk of all-cause mortality compared to those on newer antidepressant classes. Thomas, 76, was prescribed low-dose amitriptyline for diabetic foot pain. It worked well, but over the following months, he developed dizziness when standing. One morning, rising from the breakfast table, he lost consciousness and fell, fracturing his wrist and striking his head. Textbook orthostatic hypotension from the amitriptyline, a known effect that had never been discussed. Be completely honest right now. If you are on amitriptyline or any medication ending in triptyline or pramine, has your physician checked your resting electrocardiogram since starting that prescription? Comment yes or no, because that ECG carries information directly relevant to your safety on this drug. The fix. For neuropathic pain, duloxetine and gabapentin offer meaningful efficacy with cardiac profiles considered substantially safer for older adults. For sleep, low-dose melatonin and cognitive behavioral therapy for insomnia have demonstrated clinical effectiveness without cardiovascular involvement. If you are currently on a tricyclic, do not stop abruptly. Bring the specific question of cardiac monitoring and safer alternatives to your next appointment with direct, clear language. And now, number 1, this one is perhaps the most unexpected on this entire list. Millions take it daily, believing it is protecting them. Number 1 is high-dose calcium supplements. And I need to be precise here because the distinction between supplemental calcium and dietary calcium is not a small detail. It is the entire point. Your bone density scan shows osteopenia. A calcium supplement is recommended 1,200 milligrams daily. You are doing exactly what you were told for decades. And here is what that messaging has consistently failed to communicate. When you eat calcium from food, dairy, leafy greens, fortified products, Your digestive system absorbs it gradually in small quantities. The biological infrastructure for handling dietary calcium works as it was designed to work. When you take a high-dose calcium supplement, you create an acute spike in circulating calcium that your regulatory systems were not built to process. Your bones can only absorb so much at once. The remainder deposits in soft tissues, including arterial walls, a process called vascular calcification that hardens arteries and advances the conditions leading to myocardial infarction. Think of it this way. Dietary calcium is like rain soaking into soil. The ground absorbs what it needs and the rest drains naturally. A high-dose supplement is like dumping a bucket of concrete into that same soil. What the ground cannot absorb hardens wherever it lands. A landmark meta-analysis published in the British Medical Journal examining 11 randomized controlled trials involving 11,921 participants found calcium supplementation associated with a 27% to 31% increased risk of heart attack. A 2016 analysis in the Journal of the American Heart Association following 2,742 adults over 10 years found high supplemental calcium from pills, not food, associated with a 22% greater likelihood of coronary artery calcification progression. Eleanor, 70, had no classic cardiac risk factors. No smoking, cholesterol managed, blood pressure stable. She had taken 1,200 milligrams of calcium carbonate daily for years. When she suffered a myocardial infarction, imaging revealed significant coronary artery calcification. The supplement had been the quiet driver without a single warning symptom. Until the event itself, be completely honest right now. Are you taking a standalone calcium supplement? And did your physician actually assess your total dietary calcium intake before determining the dose? Write the milligram amount on your label in the comments. Because the evidence suggests many older adults are supplementing calcium their diet already provides adequately, creating unnecessary vascular exposure without meaningful additional bone benefit. The fix: have your dietary calcium intake assessed before assuming you need a supplement. If supplementation is medically indicated, calcium citrate is absorbed more effectively at lower doses than calcium carbonate and produces a smaller serum spike. Pairing any calcium supplement with vitamin K2, specifically MK7 form, has been shown clinically to direct calcium toward bone tissue and away from arterial walls. For most older adults, 500 milligrams or less in supplement form, alongside adequate dietary intake, reaches the therapeutic threshold without the vascular exposure that higher doses carry. If you have been taking one or more of these medications for years, if some of what you heard today describes your current daily routine exactly, I want you to hear something important. It is not your fault. You were not given this information. Your pharmacist did not have time to walk through the cardiovascular implications of everything in your bag. Your physician, working within a 15-minute appointment, was following the guidelines in front of them. The system that was supposed to protect you did not give you what you needed to protect yourself. The human body's capacity for recovery continues to humble me after 2 decades of watching it work. Arterial inflammation can recede when the chronic trigger is removed. Magnesium levels can be corrected and electrical stability restored within weeks. What we covered today is not a sentence, it is a starting point. Here is what you now understand that most people have not fully considered. A medication prescribed to help one system can create measurable strain on another. Over-the-counter does not mean low risk, and the dose appropriate at 50 may not be appropriate at 70, not because something is wrong with you, but because your body's physiology has fundamentally changed. You are no longer a passive recipient of prescriptions. You are someone who can walk into that appointment with specific questions and advocate for a treatment plan that sees you as an individual. That is not a small thing. That is everything. Let me give you specific steps you could take starting tonight. First, write down every single medication, supplement, and over-the-counter product you are currently taking, including vitamins and anything you take occasionally. A complete, accurate list is the foundation of every informed conversation that follows. Second, check every cold, allergy, and sleep product in your cabinet for pseudoephedrine, phenylephrine, or diphenhydramine in the active ingredients. If you find them, identify the safer alternatives we discussed. Third, flag any PPI, tricyclic antidepressant, high-dose calcium supplement, or daily NSAID on your list. These are your priority discussion items at your next appointment. Fourth, ask specifically for magnesium to be included in your next routine blood draw. It is frequently not part of the standard panel, and many deficiencies go undetected simply because it was never tested. Fifth, if you take low-dose aspirin for cardiac protection, confirm with your physician that no NSAID is being taken alongside it regularly. That interaction is documented and completely avoidable. And finally, have an informed conversation with your doctor. Bring your list, ask specifically, given my age and everything I am currently taking, are there any cardiovascular interactions I should be monitoring? And is there anything here that was prescribed short-term but never revisited? You deserve a physician who treats that question as exactly what it is, a patient who takes their health seriously. Drop a comment right now saying protected. If this gave you something real today, if it answered questions you've been sitting with, or changed how you are going to look at your medicine cabinet tonight, I want to see that word. Now think of one specific person you love, someone who takes a handful of pills every morning and has never had a conversation about what those pills are doing to their heart together. Send them this video right now. Not later, right now. Subscribe to this channel. The mission is straightforward, honest, research-grounded health information that most people only encounter after something has already gone wrong. You deserve to know it before that happens. In my next video, I am going to cover the one breakfast habit quietly accelerating cardiovascular aging in adults over 60, and the research behind it contradicts what nutritional guidelines have been recommending for 20 years. You will not want to miss that. This video is for educational and informational purposes only. It is not intended as medical advice. Cardiovascular health management must be individualized based on your complete medical history, current health status, and all relevant clinical factors. Never adjust or discontinue any medication without first consulting your healthcare provider. The information presented reflects current published research and should not replace a thorough evaluation by a qualified medical professional.